Mr. P, 40-year-old gentleman from Jharkhand, carpenter, came with complaints of weakness of all four limbs for 10 days. Coming to the history of presenting illness, Mr. P was apparently well 10 days ago. He woke up in the morning and carried out his ADL normally. At 7:30 a.m., he left the house to drop his children at school on his bike. He was able to walk down 2 flights of stairs without any difficulty. He did not have any slipping of slippers or buckling of the knees, and he was able to swing his leg over the bike to sit. But when he started the bike, he realized he had difficulty clutching the brake and had difficulty turning the gears with his hands. He returned to his house and he noticed difficulty when he tried to remove his shirt over his head. The next day, he was sitting in the toilet when he noticed difficulty getting up from sitting position and had to pull himself up with support. He did not have any buckling of knees. 2 days later, he noticed difficulty in pulling himself up from a supine position. He was able to turn from side to side and turn his neck. He did not have any breathing difficulty. He did not have any feeling of walking on cotton wool and did not have any paresthesias. He did not have any bladder or bowel dysfunction. He did not have any difficulty in chewing or swallowing food. There was no change in voice or speech. He did not have any drooping of the eyelids. No history of recent vaccination, no history of diarrhea or upper respiratory infection in the last 1 month. Coming to the past history, he is a known hypertensive for 2 years on amlodipine once daily and he doesn't have any other comorbidities. So coming to the examination, the patient is vitally stable with the respiratory rate of 22, the SpO2 of 99% with the BP of 140/80, GCs of 15/15. General examination wise, no pallor, icterus, cyanosis, clubbing or pedal edema. Neck holding time was 30 seconds with single breath count was 30 seconds. Coming to the CNS examination, the higher functions were normal. There were no cranial nerve deficit. Power in the right and the left comparatively, it is mentioned here. In the shoulder, it is 4/5, abduction, flexion, elbow, wrist flexion and all the movements. In the left side, it is 3/3. In the same way, in the lower limb, it is 3/3 in both the limbs. Sensory system was normal. There were no extrapyramidal symptoms. Coming to the deep tendon reflex, it is absent bilaterally, while in the knee ankle, it was present bilaterally. Plantar was flexor in both the limbs. Cerebellum cannot be assessed due to weakness. There were no meningeal signs and spine was normal. So systemic examination, he didn't have any abnormal findings. So coming to the syndrome complex of acute onset areflexic quadriparesis with no bowel or bladder involvement or sensory level. So Guillain-Barré syndrome was the only thing we thought of due to the acute history and the progression of the disease. So coming to the investigations, HB was 13.9 with a WBC count of 8,500, platelets of 1,86,000. Sodium and potassium was normal, create was also normal. So we went ahead with CSF, which showed cytoalbuminological dissociation with the counts of 7 with a protein of 114. EMG showed motor axonopathy of upper and lower limbs, and further workup for this anti-ganglioside antibodies came a strong positive for the patient. Anti-GM1 is strong positive. So I'm going to talk about Guillain-Barré syndrome, Amman variant. So coming to the introduction, it is an acute, frequently severe fulminant polyradiculopathy and it is autoimmune in nature. So what is the difference in AADP and Amman? AADP is the common presentation of the Guillain-Barré syndrome and not Amman variant, acute motor axonal neuropathy. So the neuron involved in this, both the part of the neuron involved in both the condition is a little different. In the acute inflammatory demyelinating polyneuropathy, the commonly involved thing is the myelin sheath. So in the myelin is degenerated in the AADP variant, whereas in the Amman variant, the node of Ranvier is involved. So the patient usually have the severe weakness as the node of Ranvier helps in the saltatory conduction. So in demyelination variant, they also have severe weakness. Because of this involvement in the node of Ranvier, they also go ahead to Wallerian degeneration. So the recovery of the nerve is very much late compared to the AADP variant, as myelin can be formed with the Schwann cells after it is completely destroyed. So how common is Amman? So here is another thing explaining the demyelinating form. There is conductional block. The axonal connection is intact. Rapid recovery as myelination occurs, whereas in the severe form, the axonal degeneration also occurs. So it has slower recovery, whereas in Amman, because of the node of Ranvier involvement and Wallerian degeneration, the recovery is very slow. So this is the incidence of the GBS variants. The commonest presentation is AIDP constituting about 52%, whereas Aman variant constitute about 30%, Amsan variant constitute about 14%, Miller-Fisher syndrome constitute about 4%. So coming to the antibodies in the GBS spectrum. So our patient had acute motor axonal neuropathy and he had GM1 positive, whereas in acute inflammatory demyelinating polyneuropathy, antibodies are not usually present. In Aman variant, about 50 to 60% of the people will have antibodies positive. In Miller-Fisher syndrome, GQ1 antibody will be present in almost more than 90% of the patients. So in AADP variant, testing for antibodies is usually has very less negative predictive value. In Miller-Fisher syndrome, it is usually helpful in diagnosis also, as it is present in more than 90% of the patients. So coming to our patient had asymmetric weakness of power in 4 and 3 in the upper limb and the lower limb, and the reflex were also present. So is asymmetric weakness common in Guillain-Barré syndrome? In children, 23% of atypical symptoms is asymmetric weakness, but in adults is usually rare. So there are some case reports in the literature that saying that the patient initially presented with features of hemiplegia, and further it progressed to involve the all four limbs, presenting as areflexic quadriparesis. So this is another literature which showed the 60-year-old gentleman with the acute onset left hemiparesis and left hypoglossal nerve palsy with normal reflexes. Initially, he was diagnosed to have hemiplegia. CT brain done was normal. So after 3 to 4 days, it progressed to involve the right upper and lower limb also. And the reflexes that were involved, it became areflexic after 3 to 4 days. The EMG done at that time showed diffuse motor axonal neuropathy. And the IgG anti-GD1 antibody was also positive in this patient. So he was treated with IVIG. After treatment, the prognosis is unable to stand on his own 1 month after treatment. So in this literature, we're finding that even the patient presenting with asymmetric weakness, presenting as left hemiplegia or hemiparesis, if they progress to involve the all four limbs with areflexic quadriparesics in the course of the disease, we should think of GBS, because in the course of the disease, it will progress till 4 weeks and then to achieve a plateau. So in this meantime, the patient can have asymmetric weakness and further progress to, in the 4 weeks time, have symmetric weakness with areflexia and quadriparesis. So this is the factors that cast diagnosis of Guillain-Barré syndrome. The first thing is marked persistent asymmetry of motor function. So in that 4 weeks time, the patient still have persistent asymmetric weakness. We should think of other diagnosis of GBS, and in this 4 weeks time they progress to develop this symmetric weakness, we should still think of GBS as a clinical diagnosis. And the patient having persistent bowel or bladder dysfunction and sensory involvement is not common in the GBS. If they have a discrete sensory level, we should not think of GBS. And the cerebrospinal fluid showing more than 50 cells is also against the GBS, and the patient having cranial nerve involvement and the descending weakness, we should not think of GBS in these patients. So coming to the prognosis and recovery, so 85% full recovery within months to year, but in this there is other study which shows in this only 61% have full recovery and 25% have 25% have full recovery, 61% have full recovery, good recovery with minimal residual weakness, 14% have partial recovery. So mortality rate is less than 50% because of the respiratory muscle weakness, and cause of death is secondary pulmonary complications. The factors worsening the recovery are advanced stage, permanent or severe attack, and delay in starting treatment. In the Aman variant, because of the node of Ranvier involvement and the Valerian degeneration, they usually have very long course of this recovery. They, even after 3 months of this good rehab, they might still have this residual weakness. So compared to the Aman variant and the AADP has good prognosis compared to the Aman variant. So coming to the summary, the AADP, we learned about the part of neuron that is involved in AADP versus Aman. The antibodies in GBS, it is usually non-significant in AADP variant. In Miller-Fisher, it has good negative predictive value. In Aman variant, it is present in more than 60%. And asymmetric weakness can also present in GBS, but in 4 weeks of time, if you observe it, they might have this areflexic symmetric pattern. If there is persistent asymmetric weakness, we should think of other causes. And in the axonal variant, due to Valerian degeneration, they might have a slow recovery. as it will take time for the neuron to fully develop. Thank you.
What happened to this patient, Brightlin?
So our patient had this asymmetric involvement. So unlike other, usually it will plateau in 4 weeks time. Our patient reached a plateau in 10 days time, and he didn't have further worsening of respiratory muscle weakness. His power is always in the range of 4 and 3. He was planned for a plasmapheresis and he received 4 cycles of plasmapheresis. After that, he had very little improvement. He was advised about the prognosis of the Amman variant as it will take time for him to reach the normal level, but it might not be possible as he might have residual weakness. So he was advised rehab and discharged. He received 4 cycles of plasmapheresis.
Thank you, Brightlin. Now Evangeline will be presenting. Evangeline's case is Beat the Fate.